The mammary gland is a modified sweat gland. That is why it has no capsule or sheath around. The size of the breast is determined by the amount of fat surrounding the glandular tissue, except during pregnancy, when the mammary gland enlarges and new glandular tissue forms. The roughly circular body of the female breast rests on a bed that extends transversely from the lateral border of the sternum to the mid-axillary line and vertically from the second through the 6 ribs. 2/3 of the bed of the breast is formed by the pectoral fascia, overlying the pectoralis major muscle. The other third by the fascia covering the serratus anterior. A small part of the mammary gland may extend along the inferolateral edge of the pectoralis major towards the axillary fossa, forming an axillary process or tail of Spence. Some women discover this, especially when it may enlarge during a menstrual cycle, and become concerned that it may be a lump or enlarged lymph nodes. The mammary gland is firmly attached to the dermis of the overlying skin, especially by substantial skin ligaments called Cooper's ligaments. These condensations of fibrous connective tissue particularly well developed in the upper superior part of the gland, and they help to support the lobes and lobules of the mammary gland. The lactiferous ducts give rise to buds that develop into 15-20 lobules of the mammary gland, which constitute the parenchyma, or functional substance, of the breast. The milk-secreting acini are arranged in grape-like clusters. Each duct has a dilated portion deep to the areola, the lactiferous sinus or ampulla, in which a small droplet of milk accumulates or remains in the nursing mother. Now let's review the vessels which supply the breast. The first feeding source here is the subclavian artery, which gives off the lateral thoracic and the internal thoracic arteries. Both have mammillary branches. And the second source is our descending thoracic aorta via the intercostal arteries. The intercostal arteries give off some perforator branches for the breast. The venous drainage of the breast is mainly to the axillary vein, but there is some drainage to the internal thoracic vein as well. The sensation of the breast is provided through the anterior and lateral cutaneous branches of the 4th, 5th, and 6th intercostal nerves. The T4 nerve supplies sensation to the nipple areola complex, and this one is the most vulnerable nerve in breast implant and other breast surgeries. Well, no more boring stuff. We are moving to the interesting part now. The milk-secreting acini form 15 to 20 lobules. The lobules open into the lactiferous ducts, and the lactiferous ducts are drained by the lactiferous sinuses, located just under the skin in the area of the areola, approaching an opening through the nipple. The majority of breast cancers begin within the terminal ducts, lined with the columnar epithelium, right here. And the reason for that are the hormonal changes women experience each month. Several hormones act on the ductal epithelium, such as estrogen, progesterone, prolactin, oxytocin. I'm not even mentioning the hormones of pregnancy now. Some of these hormones induce the proliferation of the epithelial and glandular cells. Others activate the apoptosis of these, and this happens over and over again each month. Such high cell turnover leads to the accumulation of defects and makes the breast sensible to the development of cancer. Luckily, it's easy to diagnose this type of cancer. Everything is on the surface. The ductal carcinoma in situ is the earliest precancerous stage of breast cancer, stage 0. And doctors' goal nowadays is to find a way to catch cancer at this stage. DCIS rarely produces any symptoms or a breast lump one can feel, and is usually detected through screening mammography. If you examine the biopsy of such breast under a microscope, you will see that the abdominal cells are located only in the epithelial lining of one or more noctiferous ducts. They have not moved out of the duct and into any of the surrounding tissues. They are in situ, which means in place yet. As disease progresses, the abnormal cells may become invasive and spread to other tissues. But there is no way of determining which lesion will remain stable without treatment and which will go on to become invasive. If the growth spreads, the cancerous cells will form a lump and grow through the walls of the lobules and lymphatic vessels around. Understanding the lymphatic drainage of the breast is of practical importance. So let's look at it. For descriptive purposes, the breast is divided into 4 quadrants: superior, medial and lateral, and inferior, medial and lateral. First, the lymph passes from the nipple, areola and lobules of the gland to the subareolar lymphatic plexus. Then, it is distributed between the parasternal lymph nodes from the superior medial quadrant, subdiaphragmatic lymph nodes from the inferior medial quadrant, and the axillary lymph nodes from the lateral quadrants of the breast. In 70% of cases, breast cancer develops in the lateral quadrants, and the pectoral anterior axillary lymph node catches the metastatic cells first. Involvement of this lymph node into cancer indicates stage 3 of cancer and determines the scope of the surgical intervention. If the pectoral lymph nodes are clean, it could be just a resection of a part of the breast. But if it has cancerous cells in it, the breast will have to be removed completely and all axillary lymph nodes will be dissected. But how can we find and check this first guardian lymph node on the way to metastasis? Should we dissect and examine microscopically all lymph nodes of the axilla? It is possible, but it isn't an easy task, and it may lead to complications like chronic lymphedema of the upper limb. We need to identify the first lymph node that may be linked to the tumor and do not take too many others. This first lymph node is called the sentinel lymph node, and the technique is referred to as the sentinel lymph node biopsy. First of all, the appropriate patient must be selected by reviewing the images and the patient's history. The main condition here is being node negative during the physical examination. Then the radioactive solution is injected into the peritumoral location. The spot is marked on the skin, as well as the pectoralis major and latissimus dorsi muscle. The navigator probe is used to identify the location of the hot spot. The blue dye is injected at the peritumoral depth, along the lateral aspect of the tumor next to the axilla. The local manual massage is utilized for 5 minutes to facilitate the drainage towards the sentinel lymph nodes. Then the skin incision is made beneath the axillary hairline. The incision is carried out by electrocautery to avoid bleeding. The clavipectoral fascia is identified under the superficial fascia and dissected. Just under it, the blue-colored lymph channels become visible. Careful dissection along the blue channels helps to find a blue lymph node. This lymph node is dissected from the surrounding tissues. The navigator probe is used to confirm that the right sentinel lymph node is taken out and that no other lymph nodes related to the drainage of the tumor are left in the operative wound. The node is then submitted to the pathology